Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Borja del Pozo Cruz in Cadiz, Andalusia, and Dr. Rubén López-Bueno in Zaragoza, Aragon, with whom we would like to discuss the impact of regular physical activity on cardiovascular outcome and overall survival in the general population, based upon their epidemiological research that has recently been published in JAMA Internal Medicine. So for the second time within few weeks, we have two researchers from Spain within one webinar. Dear Borja, dear Ruben, we are happy to host you tonight. Thanks for accepting our invitation.
Welcome you both also from my side. We're really happy to have you here today because we would like to talk about sports and sports sciences today. And as our viewers will be aware of, 2024 is a year of sports, packed with sports. We have the Olympic Games and also the Euro 2024 will take place. And as you know, sport is a relevant ingredient for public health. And we have always the question, so what is the right amount of exercise? How should we train and on what level should we exercise? What is the optimal number of daily steps we should take to increase longevity? And therefore, we are really happy to have some great experts in the fields of sports sciences. We have, as Gunnar introduced, Rubén López-Bueno, who's a postdoctoral researcher at the Department of Physical Medicine and Nursing of the University of Zaragoza in Spain. And we have Borja del Pozo Cruz. He is a principal researcher in applied health sciences at the University of Cadiz in Spain, and also an adjunct associate professor in the Department of Sports Science and Clinical Biomechanics at the University of Southern Denmark. So without any further delay, we should address all those questions, and we're really happy to host you, and we're really looking forward for your data.
Yeah, thank you so much. So I thought it was important, first of all, to introduce some differences between physical activity, exercise, and sports, so that the public can understand this and how this different might apply to each of the for every person who is watching this webinar or this chat. So first of all, physical activity might be defined as any bodily movement that results in energy expenditure. So anything that we do, any step we do, any run, any step we climb, anything that moves our body and produce and result in some form of energy expenditure is physical activity, is movement. Exercise, on the contrary, is a physical activity that is planned and normally is focused on improving a fitness component. Could be muscular, it could be cardiovascular fitness, any of the fitness components, flexibility, any of the fitness components. So these two are quite different. And if you ask people about physical activity and exercise, people tend to use those interchangeably in the same manner. But I think it's important to differentiate because physical activity has perhaps more implications for public health, in the sense of there might be people that do not exercise, but they do a lot of physical activity. So if you ask people, hey, have you exercised today? Probably majority of the population would say no. But if you put an accelerometer or a smartwatch or even the smartphones that is able to count the movement that they do, there's probably movement there, and that movement is associated with health benefits. Every movement counts. That's the motto of the World Health Organization in the last physical activity for public health guidelines. So I think making this distinction is very important. In our study, we use the term physical activity, more focused though on lesser time physical activity. So things that people might engage in their lesser time rather than when they work or when they do household chores or any other type of physical activity. So I just thought that, you know, making this distinction, you know, could put people in the perspective that we or through we which we launched and did our study. Yeah, I don't know, Rubén, if you have anything to add to that, or because we focused on lesser time physical activity, right? So you can perhaps describe more, you know, what type of physical activity we differentiated, whether it was moderate and what included moderate, because I recall the questions were included as well some light intensity physical activity in that, and then how we were able to separate moderate from vigorous physical activity, and what kind of questionnaires, if you want to elaborate on that, that'll be great, I think, for the audience.
Yeah, well, thank you for having us in this in your YouTube channel, in this series concerning different topics in research areas. Borja has summarized the difference between physical activity and exercise perfectly. I don't have nothing more to add regarding this issue. Concerning the physical activity intensity that we used in our study in JAMA Internal Medicine, physical activity through questionnaires, validated questionnaires, and well, the way they divided or considered which was moderate or which was intense physical activity was considering the point in which, well, you have difficulties or you start to breathe heavier than usual. And then if the question is, if the answer is affirmative to this question, then the physical activity was considered more than moderate, and to surpass the threshold of the high intensity or vigorous intensity. So the threshold, the line between the two intensities is considered in this self-reported questionnaire we used, is considered concerning the way you breathe and the effort you feel when you are doing any type of physical activity, irrespective of this is occupational, of this is leisure, this is commuting physical activity, because domains of physical activity matter. Is something that we have investigated this few years ago, and what we have seen is that depending on the way and the domain that you do this physical activity, is more linked to get more benefits for your overall health, preventing diseases, having longer lives. And concerning this issue, we have seen, or many studies have seen, that at least leisure physical activity and commuting physical activity are usually healthier and provide more benefits than occupational physical activity. Although I must say that there is two important studies, one of them published in Lancet Public Health by Ulf Ekelund and colleagues, that they didn't observe that detrimental association between occupational physical activity and mortality. But most of the evidence that we have nowadays points towards the fact that occupational physical activity may don't be as beneficial as the other domains. Is it correct? Borja, what do you think about this?
Yeah, I mean, I'm well aware of some of those studies, and I was involved myself on some of those as well. One with you, Rubén, and I have some work in progress in this area as well. And I read Ulf Eklund's contribution recently, and it seems that once you control for confounders such as social economical confounders, that detrimental association disappear. In any case, I think is an area of interest for physical activity and more broadly for health promotion, but it still requires some in the same way that we use now accelerometers to monitor physical activity. I think it requires some more nuanced devices that are able to capture occupational physical activity per se, like some arm movements or trunk movements and the load during those activities. So I don't think we are yet any closer to any definitive answer to that, but definitely I think considering the domain physical activity, the domains of physical activities is something worth pursuing, and this is why in our study, again going back to our study, we focus on lesser time physical activity because simply the benefits seems to be clearer or less murky. Let's say this.
So that's leads me to my first question. This is really interesting, and the question is always how to quantify activity. And as you mentioned, you used accelerometers, and could you tell us something about your methodology about techniques to quantify besides that measurements with accelerometers?
We didn't use accelerometers for the JAMA Internal Medicine study, as the National Health Interface Survey, which is the survey we used to retrieve data concerning physical activity, leisure time physical activity, is based on self-reports. They used validated questionnaires, but they didn't use accelerometers. Okay, I know nowadays studies are being conducted using more accelerometers, but this is not possible with the National Health Interface Survey from the US. The thing is that they were collecting this information regarding physical activity during many years using this methodology because it's cheaper, and they can get data from a larger population. To get data through accelerometry with a large population is really expensive, and is really difficult. Sometimes you need a lot of resources. We are nowadays using accelerometer data from data sets such as the UK Biobank, but most of the existing data sets have not data based on accelerometer. So we couldn't use this information. This is a clear limitation of our study, of the JAMA Internal Medicine study. But on the contrary, the self-reported data also provided a larger data set, which is around 400,000 people participating in this study, which is really difficult to get with accelerometers. And not only that, but also the large follow-up period, because data sets based on accelerometry are relatively recent, and the National Health Interface Survey, we were retrieving data from the 80s. from the 1990s. So this data from that decade is not available in other data sets. So the follow-up period in our study is longer than most of the existing studies that use accelerometers. So it has clear strong points when you compare it with other studies, and this is this point concerning the longer follow-up, I think is a good point for our study. And of course, a limitation of our study is that the data we collected, or the survey collected, is not based on accelerometry, which can provide some type of bias, because when people report concerning physical activity, there is always some kind of bias concerning measurement.
But there may also, if I may interrupt you, also be a bias when you apply accelerometers, because surely people who take part in a study and who receive this accelerometer for a couple of days, they may be motivated to move more during these days. And once the study period stops and they have to send the device back, then they may fall back. So I guess both ways may have their limitations, may they not?
That's totally correct, Gunnar, because as you have said, and that's really fair to say, accelerometers have also limitations, because when you are wearing an accelerometer, you tend to move more, and there are studies proving that you tend to move more because someone is observing you, and when someone is observing you, you usually change your behavior. And yes, this is a bias also in the accelerometer studies. And there is also other bias. For example, accelerometers don't usually count on the stationary physical activity. For example, when you are using a stationary bike, the accelerometer is not going to count any what you are doing on the stationary bike. Or for another example, resistance training. When you are raising barbells, you are raising bars, doing heavy lifting, that doesn't count for the accelerometers. So in this sense, self-reported physical activity data is more valid to measure physical activity than accelerometers, because they count on stationary physical activity and resistance training, or flexibility training, which is another example.
Okay, let's dive a little deeper into your data. I think maybe we should cut it in half. There are two great papers in JAMA. One investigated step count and the number of step count and endpoints, and the other was certain amounts of physical activity and mortality. And maybe you could lead us through to the main findings. First the steps, and then the other.
Okay. So first of all, I think it would be fair for me to say why we focused on the steps, and that's a very simple answer if I will have that question, and it's simply because it's something that people understand, and this goes back and relates back to my first point on differentiating this between physical activity and exercise, right? So exercise, and the term exercise is for exercisers. So only people that exercise are able to relate to exercise. For the rest of the population, which is majority of the population, they don't know what it is, and they might think, oh, I'm inactive. But if you think in terms of steps, oh yeah, everyone understands steps. So we thought if we were able to, supplement the current physical activity exercise recommendations with step metrics. So how many steps do we need? Do we need more intense or less intense steps? So it doesn't matter. For broader health outcomes, that will be a great contribution in terms of public health. So that was mainly the reason why we focus on steps. And the main thing, there were three main findings from that study. First of all, any step count towards improving health. Now, we assessed in that study from memory, CVD incidence, cancer incidence, all-cause mortality, CVD mortality, and cancer mortality. So 5 outcomes altogether. And in a separate paper in another JAMA branch journals and JAMA Neurology, we assessed incidence of dementia. In all 6 outcomes, we observed exactly the same patterns. We observed a dose response such as every increase in steps was associated with less risk of disease or mortality from the very first one. So that's the main, or one of the main findings. Second, we sort of observed that the benefits plateau at 10,000 steps. So after 10,000, we sort of didn't observe any further gains in any of the outcomes that we assessed. So that's very important, because these 2 findings, I think, are telling us a couple of things at least. So the first one, these findings can be used by public health promoters, such as doctors in their clinics. So if you get an inactive patient in your clinic, say primary care, GP, standard community clinic, you can motivate that person, say, look, you don't need to do, okay, if you do 10,000 steps, yes, you get, the maximum observed benefits in studies, but you get benefits from the very first step beyond your baseline. So that's very motivating for the least active segment of the population, right? And then second is, you might not need to go, 15,000, 20,000 steps. If you're active and you're able to hit the 10,000 steps, that's enough. And probably the other important thing from those studies is that we didn't differentiate really between domains in this case. So we simply, with the accelerometry from the UK Biobank in this case, we were able to record like all the steps throughout the day. So that means that any step could count, whether it was at home, at work, or in your lesson. Probably the last important finding is that steps that were somewhat intense, that could be, if you go for a walk and then you get breathless, you are unable to maintain a normal conversation while you were walking, that we could define intense steps in that way, so that people can understand a little bit. If you, from those 10,000, let's say if you hit like 3,000 more intense, that would be even better. That would provide even more benefits for your health. I think that summarizes very much my 2 studies.
Before we come to the second paper, may I just briefly ask you, if we look at the curves that you published, there are even some curves that suggest really a U-shaped relationship. So with the best prognostic implications, if you have around about 10,000 steps, and then some of these curves suggest to go in the bad direction. And this was particularly impressive in my view with regard to dementia, which you published in the Lancet Neurology. So do you have any suggestion why this may happen?
Yeah, my first hypothesis there, and I think that's the one that we clearly stated in the manuscript, is that this is a statistical issue, really. So we didn't have many people at the higher end of a step count. And because we don't have many people there, and the number of events is also low, you can see the confidence interval is going super wide, right? So that is the main, to me, that's the main reason why we observed such a U-shaped curve there. But in reality, we couldn't even interpret properly more than beyond 10,000, 12,000 steps. That is my take, and that was our discussions as well. I got these questions from reviewers, but it's purely a statistical artifact of the data, which in itself is very interesting, because it's posting the question of, okay, and this data doesn't exist yet, but it would be super interesting research study. What happened with the people that do a lot of steps, like 20, 25,000? If we were able to collect, to have a data set with such data in it, it would be super interesting to analyze what happened down the track with their health outcomes, including mortality or CVD. But unfortunately, we don't have yet. I think there's people that is trying to pull together a data set, such a data set, but we don't have yet availability to that. So in my view, and just to recap, is simply a statistical artifact.
Okay, great. Thank you. So going further on from step counts to different forms and different combinations of moderate or vigorous exercise. So Rubén, would you like to give us a brief wrap up on your paper?
Yes, concerning the main results, the main findings of the JAMA Internal Medicine paper regarding combinations of moderate, vigorous, and muscle strengthening physical activity. Concerning this paper, we saw an interesting issue that we are nowadays trying to delve more into, which is that every of the 3 types of physical activity, each of them provides or may provide different benefits through probably different mechanisms. And which is most interesting about this is that if you want to live longer, or if you want to prevent this more common diseases regarding cardiovascular health, mainly cancer, you may do these 3 types of physical activity. Okay, you should do at least a minimum of moderate physical activity, a minimum of vigorous physical activity, and a minimum of 2 training sessions of muscle strengthening physical activity. What we saw is that a combination of these 3 types of physical activity is optimal to get higher reductions of all-cause mortality and cancer and cardiovascular mortality. This is compulsory. If you want to optimize the lower risk, or you want to lower your risk of mortality in an optimal way, you need to do at least these 3 types of physical activity. If you want to get an optimal reduction, then you need to do at least 2 muscle strengthening physical activity training sessions per week. So this is a finding that we consider that is really critical, because, okay, we know that the World Health Organization is nowadays recommending muscle strengthening physical activity and aerobic physical activity, but they don't do any distinction between moderate and vigorous in the sense that both of them are necessary. Okay, they recommend, okay, do 150 minutes of moderate physical activity or 75 minutes of vigorous physical activity, or an equivalent combination of the two. But they don't recommend, please, do some moderate physical activity and do also some vigorous physical activity. So do the two types of aerobic physical activity and add to this aerobic physical activity, please add 2 sessions of resistance training per week. And then you will get an optimal benefit to reduce your mortality risk.
This is very important for us because we see so many patients who come to us, cardiologists, nephrologists, who tell us, well, I do not do regular physical activity, but it's exercise, but I do my gardening, I do household work, so I'm active all day long. But based upon your results, you would clearly recommend them to do at least 3 times per week or so some vigorous exercise in addition, which would mean either to go jogging or for at least a brisk walk in order to really start sweating, if I got it right.
Yes, you are correct, Gunnar. What we have to consider here is that maybe vigorous physical activity for an older person is simply jogging or walking at a brisk pace. But for a younger person, a younger adult, this might not be enough to be considered as vigorous physical activity. So it also depends on the age, the sex, and maybe also your physical fitness. It also depends on this, just to consider what is vigorous physical activity for you might not be vigorous physical activity for me, might be moderate, okay? Or the other way around. But what we have seen, because our study is more based on medium age and older adults, is that considering this starting to breathe heavier issue, so that you can consider that well, then you are starting to do vigorous physical activity because you are accelerating your breath and you are feeling that you are doing more effort than usual. Then we can consider this vigorous physical activity. And yes, if you are not doing this type of vigorous physical activity and you are not feeling these symptoms, then you are not making the most of your time to reduce your mortality risk. Okay, it's better if you do something than if you do nothing. Okay, it's always it's always better to do any physical activity. Okay, because you will reduce. I don't mind if it's moderate physical activity. I don't mind if it's vigorous physical activity or muscle strengthening physical activity. You are going to reduce your mortality risk. Okay, doing any of these 3 types. Sometimes people are really busy and they don't have time to do these 3 types of physical activity, and it's easier for them to do moderate or sometimes several minutes of vigorous intensity physical activity, but they don't have the resources or they don't have time to go to the gym and do some resistance training. But if you are able to, and you have the time, and you want to live longer and a healthier life, it is recommended, according to what we have observed in this study, it is recommended that you do the 3 types of physical activity.
If someone tells you, well, as you mentioned, I do not have enough time, is there any data to support an accumulation of all those three forms in maybe 1 or 2 sessions?
Yeah,
a week or so.
We didn't examine when these 3 types of physical activity were done. We didn't observe that. We didn't have the data, but this is a really interesting question. The data we collected is based on a weekly basis. But we don't know if the vigorous physical activity they did was the same day that they did muscle strengthening physical activity. We don't know that because we don't have that data. That will be really interesting to have. But what we know up to now is that with the weekend warrior hypothesis, there are several papers published regarding this. Irrespective of the accumulation of physical activity, I mean, if you do most of your physical activity on the weekend, or if you do it during the weekdays, from Monday to Thursday, it doesn't really matter concerning the reduction of mortality risk. It doesn't matter. So we have observed, not us, not Borja and me, but other researchers have observed in important studies, also published in JAMA, that the pattern, the way you accumulate your physical activity is irrespective of if you accumulate on weekdays or you accumulate more physical activity in 2 days, on Saturday and Sunday, which is also called the weekend warrior pattern. So irrespective of this, you will also get similar mortality risk reductions. There is an really critical study published by Karsid and colleagues in JAMA that is based on this topic, and these are the main conclusions of the study. It's totally irrespective if you do physical activity concentrated in 2 or 3 days per week, or if you do it more spreadly along the week. It doesn't matter. Which matters is the quantity and the quality. These 2 things, but not the spreading of the physical activity.
With regard to the muscle strengthening activity, our patients really have to go to the gym, or can this also be done at home, like some push-ups, sit-ups, pull-ups, again, surely depending on the strength of the individual patient? But does this really require a gym, which also takes some time and surely some money to go there?
No, it doesn't require a gym. In fact, several questions, not in our study, but in other studies, they have question about it. Where do you usually do your resistance training? At home, in a gym? And irrespective of this answer, you can do it at home or in a gym. The benefits are going to be the same. I will also focus more on the type of exercises, but which is mostly recommended is the whole body exercises. Whole body exercises like squats, push-ups, Olympic movements such as jerks and snatch, you know, these movements, these exercises that implies the whole body, these are highly recommended because you are working in a balanced way most of your muscles, and you are saving time because you are not going one by one muscle, one by muscle, which is you're more a bodybuilding bodybuilding plan. But when we speak about health, concerning health, the types of plans concerning resistance training are different than bodybuilders. So we look more for whole body exercises, implying more coordination, and not focusing on too much on single muscles, you know.
And 2 times per week, 10 minutes or so would be fine for our patients and sufficient?
Yeah, it's enough with 2 sessions per week. 10 minutes, 15, 20 minutes, but 10 minutes if you are efficient enough and you include 4 or 5 exercises involving the whole muscles of your body, then it's enough.
And with regard to the mechanism of exercise, if I do cardiorespiratory fitness, well, I know I protect heart and vasculature, but with those types of core fitness or even muscle strength fitness exercises, could you speculate on the mechanism? What is it that that makes those activities protect us from dying?
Borja, would you like to answer?
Yeah, I can give it a go. So there's few probably mechanisms that might be in place there. So the first one is that if you work your muscles, you keep mobile for longer, right? So that keeps you moving for longer. So that will that implies that you're healthy for longer and you'll die later. So that's first. Second, muscles and metabolism are connected. So you move your muscles, you know, you're doing a favor to your circulatory system, which impacts your head, but also impact your brain. So it keeps you healthy overall. And also, you know, if we think about weight, which is a major concern for many non-chronic diseases, sorry, non-NCDs, non-communicable diseases, I would say. So, you know, when you work your muscles, you create an energy deficit, which means you are burning calories and energy even, you know, after you are done with your exercise sessions. That's definitely a benefit. So there's multiple mechanisms by which, you know, keeping your muscles strong will make you a favor and will increase the longevity of people in general.
Yeah, and also don't forget that you are also preventing sarcopenia. You are also preventing osteoporosis. You know, you are increasing your bone density, bone mineral. These have also implications directly connected with your health, since your muscles are healthier, your bones are healthier, your joints are healthier. You are also preventing arthritis. Then you are going to move more. So it's everything connected. Everything is connected regarding and if you move more, your cardiorespiratory system is going to be trained. Your physical fitness is going to be higher. And as we know, when your physical fitness is higher, your your risk for mortality is lower. So everything is connected, and everything matters. And of course, muscle strengthening activity plays a role, and plays a different role than aerobic physical activity plays. In some ways are connected, because you can also train aerobics with raising barbells. If you do it with a lot of repetitions, without no rest, okay, your heart is going to, your heart rate is going to increase, and similar adaptations that you also get with jogging or with other cardiorespiratory more involved exercises. You are able also to get with muscle strengthening, depending on the orientation that you give to your training. Okay, but there is also true that the benefits that you can get concerning bones, joints, and muscles when you do muscle strengthening physical activity are different, and probably are higher, and there are more benefits for these components of our body with muscle strengthening physical activity than with aerobic physical activity, which usually focus more on the cardiorespiratory system. So the two ways are important to do in order to provide benefits to different body systems. Do you agree, Borja?
Yeah, absolutely. I think we're all on the same page. I think we all here agree that we need to engage in both types of physical activity to maximize and to optimize the health benefits of movement.
So great, as time flies. Borja, I think this was a good conclusion to this topic. We learned a lot today. Thank you both. I think maybe the two key figures I'm taking home is that every step counts to reduce mortality and reduce risk. And if you have done 10,000 steps, you can stop. And of course, everybody should combine a different form of exercise, moderate, vigorous, and even muscle strength. And I think this is a really important notice for our patients, that we should communicate in daily clinical practice. So I think this is a really relevant field, and those are relevant facts for daily practice. So thanks for having you both here today. Thanks for coming, and for the sport year 2024, all the best. Thank you.
Thank you.
Thank you.
Thank you.